Basically, hypertension is an age-related disease, which is the most important risk factor for hypertension is aging. And there is a very deep modification in function and structure of our vessel, both at the level of microcirculation, large arteries, especially aorta. The main alteration in aorta is increase in stiffness, so aorta loses its elastic properties. And while at the level of microcirculation, small arteries, we have both functional alteration, the first step, which is endothelial dysfunction, then structural alteration, increase in medial lumen ratio, that leads to increase in peripheral vascular resistances. So we lost the elasticity of aorta, we increase peripheral vascular resistances, and this is one of the main mechanisms leading to hypertension.
So we have an increase in peripheral vascular resistance, which again increases the blood pressure. So we have another part of the vicious cycle coming into operation. Dysfunctional endothelium, increased vascular peripheral resistance, and then we have increased blood pressure, and this leads to further stiffening of the large arteries, and then the vicious circle does not end. It continuously operates. We know that all the traditional risk factors that they increase cardiovascular risk, they have an adverse effect on both the endothelium and on arterial stiffening. Obesity, smoking, hypertension, dyslipidemia, they all affect both the endothelium and arterial stiffening. So they have a synergistic effect on the cardiovascular mechanisms. They lead to hypertension, and also they lead to increased cardiovascular risk.
What I've learned over the years, taking a look at all of the data, is number one, the majority of people are going to get a RAS inhibitor as primarily first line or second line, because 70 to 80% of people in hypertension have activated renin-angiotensin system. I think the first line choice would always be an ACE inhibitor.
Tissue ACE is the crucial enzyme involved in this pathological process, because first, tissue ACE can cause the production of angiotensin II from angiotensin I. Angiotensin II is a basic substance in vascular homeostasis, and when there is dysfunction because of oxidative stress, reduced nitric oxide availability, angiotensin II becomes a bad guy, because it can lead basically to inflammation, to production of oxidative stress, and is a very potent metagenic substance. So it's deeply involved in all the steps leading from a normal vessel to a pathological vessel. ACE can degrade bradykinin to inactive segment. Bradykinin is one of the most potent endogenous substances protecting vascular wall, because it has several anti-atherosclerotic activity, mainly mediated by the activation of endothelial function.
I think I am a great believer from my clinical practice and trials that I've read, and mechanistic studies, clinical studies that I've seen, that ACE inhibitor is a more powerful drug than ARB, because there are other things that ACE inhibitor mechanism brings, such as the bradykinin and other kinins. So there are, apart from blocking the renin-angiotensin system, which is extremely important, there are other effects that also lower blood pressure, increase vasodilation, which we don't have with the ARB, which is more specific and simply works through the renin-angiotensin system.
And even in hypertension, the recent Van Vark meta-analysis would suggest numbers needed to treat in contemporary ACE inhibitor trials to prevent one dead body was approximately 65 or 66 people, whereas the same analysis in the ARB trials was 335 and was not statistically significant.
Perindopril has a unique mode of action. First of all, it's lipophilic, so it penetrates the vessel wall and has an effective reduction in angiotensin II. and by this way it protects from vasoconstriction, and also it protects from all the unfavorable effects of angiotensin II, such as oxidation effects or unfavorable effect on the endothelium. But on the other hand, it does not affect the bradykinin. So the preservation of bradykinin retains the beneficial effects that this substance has, which is the increased bioavailability of nitric oxide, and through this mechanism we have a better vasodilation, we have a protection of the endothelium, and we have less vasoconstriction, less proliferation, and less inflammatory actions.
By this mechanism of action, perindopril has the best documented effectiveness in vascular protection. Several studies performed in almost all cardiovascular bed, micro and microcirculation, every kind of artery, from peripheral artery to coronary artery. There are studies, well-published studies in important scientific literature demonstrating that perindopril can offer a specific vascular protective activity.
We know that perindopril protects the vessels. It maintains vascular health through its effect on the endothelium, arterial stiffening, and central blood pressure reduction. And this translates to beneficial effects into the clinical level. We have very compelling evidence in terms of protection in all the cardiovascular spectrum, from patients that do not have evident cardiovascular disease, to patients that have multiple risk factors, to patients that have diabetes, to patients that have evidence of coronary artery disease, stroke, or even patients with heart failure.